I thought of starting with the impact of PPH in relation to clinical management in Sri Lanka and globally, and then going on to the introduction and key sections of the guideline. And I would also like to share with you some updates from global health agencies. Okay, right. So, as you can see here, most recent data from maternal death reviews indicate that around 3 to 8% of maternal deaths occur due to postpartum hemorrhage. And out of those maternal deaths, more than 50% are preventable. The most common cause of maternal deaths worldwide is postpartum hemorrhage. And 5th October has been named as World PPH Day by the global health agencies last year. And they emphasize that no woman should die from preventable postpartum hemorrhage. So, keeping that in mind, that no woman should die from preventable postpartum hemorrhage, now in our guidelines, the 2026 national guidelines on PPH, the main goal is again to eliminate preventable deaths through through application of evidence-based practices in Sri Lanka. So it is a collaborative effort of several colleges, SLCOG and College of Anesthetists and Anesthesiologists and Intensivists of Sri Lanka, and College of Hematologists and College of Transfusion Medicine Specialists. So it is a unified evidence-based standard to replace previous conflicting guidelines. So we have taken recommendations from WHO 2023 guideline, and then FIGO 2022, and many other international reviewed published articles, many, and all of which I cannot mention in here. So, but the two main recommendations we have taken from WHO and FIGO guidelines. So, some recommendations actually we have strategically modified to suit our Sri Lankan setting. And Sri Lankan women mainly. So, okay. So there are some challenges identified in the current management, which we have to address. The first challenge is missed or delayed diagnosis. So that life-saving treatment is not promptly initiated. Second challenge, slow and fragmented delivery of interventions. Thirdly, late escalation of care. And most importantly, poor in uptake of available recommendations at the point of care. So, quick actions to avoid these delays can make a big difference between life and death for a woman with postpartum hemorrhage. Right. So how can we define primary postpartum hemorrhage? You all know the definition, blood loss equal or more than 500 ml within 24 hours of delivery, normal vaginal delivery or cesarean section. But now the global health agencies in their consolidated guideline recommends using this clinical judgment-based definition. That is, blood loss equal or more than 300 ml plus presence of one or more abnormal signs, such as pulse rate more than 100, systolic blood pressure less than 100, diastolic less than 60, and shock index more than 1, and presence of atonic uterus. So this is the global definition of PPH. Now, how can we assess the severity of PPH? You all know about this. We classify minor, major, and severe postpartum hemorrhage. So severe is more than 2000 ml of blood loss. And in addition, the rate of loss is also considered. If it is more than 150 ml per minute, then again it becomes a severe hemorrhage. And massive hemorrhage is defined as loss of more than 40% of total blood volume, where the blood volume is calculated in a pregnant woman as 100 ml per kg, and this is a life-threatening situation. So again, in the global definition, they, in addition to, they don't talk much about the volumes. Main thing is refractory pH and life-threatening pH. Refractory pH is continuous bleeding despite the first response care bundle treatment. And life-threatening PPH is presence of shock or collapse or organ failure. So here, what is emphasized is in our guideline is to use objective quantification using calibrated drapes. Now you all know that we don't have calibrated drapes at present, but I think they are going to make it available very soon, because the objective quantification or objective measurement is the most important than subjective, because with subjective assessment, we can have delay in diagnosis. So emphasizing the objective quantification using calibrated drapes, and during cesarean section also there are methods. I will come to that later. So anticipation of hemorrhage is very important, because any pregnant woman is at risk of a major PPH with or without having any risk factors. There are so many risk factors, but the correctable risk factor, one of the correctable risk factor is anemia, and the other one is the avoidable one is medically not indicated cesarean section, because during cesarean section, blood loss is 3 times more than with vaginal delivery. So if we are doing unnecessary cesarean sections, then we have to anticipate more postpartum, more cases of postpartum hemorrhages. Okay, so prevention. So in the prevention, we have to optimize the woman's hemoglobin. The target value given is selected is 10.5 for Sri Lankan women. Whereas WHO gives a higher number, 11 grams. So in addition, we have to prevent, maintain the volume by preventing dehydration in the peripartum period. And the high-risk women should be managed in special units with all appropriate facilities available. And active management of third stage of labor is very important, where the recommended drug is syntocinon. Now again, in the prevention of PPH, the dose of oxytocin or syntocinon, what we recommend in our guideline is 5 milligrams, whereas if we are giving IM, it is 10 milligrams. Right. So, and the other most important thing is the observations. Postpartum observation should be recorded in a MEOS chart every 15 minutes, so that trigger points can be identified and can initiate appropriate responses. So here in our guideline, we indicate good practices. So if all women in labor should have at least 18 gauge cannula inserted. Every woman in labor should have this cannula inserted. And women with one or more risk factors should have a bigger cannula inserted, 16 or 14 gauge, and have 1 unit blood reserve. And assessment of blood loss should be done using a calibrated drape for vaginal delivery. And during cesarean section, gravimetric, volumetric, or colorimetric methods should be used. Gravimetric means weighing the sobs and the soak towels. So dry weight and wet weight, and where so you have to measure dry weight first, and then, but at present we are not doing these things. So we have to start doing these things. Where 1 ml is equivalent to 1 gram of after reducing the dry weight from the wet weight. Volumetric is in the suction bottle. Again, now it is advised to use 2 suction bottles. So the first suction bottle is for the amniotic fluid. Soon after entering the uterine cavity, they suck out before delivering the baby, suck out secretions, not secretion really, the amniotic fluid. So after sucking out amniotic fluid as much as possible, then the suction apparatus should be changed to the second one, so that the blood, what is the volume of blood loss can be measured more accurately without getting diluted with the amniotic fluid also in the same bottle. The colorimetric method is more advanced method. So for that, the colorimeter is required, where we can assess the hemoglobin concentration, and from there, the volume of blood can be calculated. Another good practice is to assess regularly, every 15 minutes, uterine tone and fundal height as a routine postpartum observation, and to maintain the Meos chart at least for 2 hours in the postpartum period. So this is the Meos chart. When the Meos score, where you can get the Meos score. If it is more than 7, that indicates high risk. And in addition, the color coding system, if it is red or yellow or orange, then it indicates the high risk situation. So shock index also should be marked in the same Meos chart. So where when it is more than 1, it is abnormal or indicate the high risk situation. So how to get the shock index? Heart rate divided by systolic blood pressure. So the normal shock index is around 0.6 or less than 1. When it is going above, when it is becoming 1.345, it is indicates the risk, the progressively increasing risk. Okay. So in the management of postpartum hemorrhage, now the most important thing in the guideline, what we are recommending is to use this emotive care bundle. Most of you all may have heard about it. So here, emotive first is early detection. And then motive is actually the treatment bundle, where there are 5 immediate simultaneous treatments, which should be done within 15 minutes of detection. And this is recommended for all women having vaginal birth. And this is not recommended to be used in during cesarean section. what is actually it's under evaluation, still under evaluation is E-master for cesarean section. So I think it will come in near future. So, so E-motive for the vaginal delivery and E-master for cesarean section, where master is, I think M is for mechanical uterine compression, and A is for additional oxytocin, and S for sutures, T for tranexamic acid, and E for escalation, and R for resuscitation. So, but it is not given in our guideline. It will come in the future as an update. So this is E-motive. So where early detection using this trigger criteria, blood loss more than 500, or what is the globally accepted definition, 300 ml with one or more abnormal observations. So with that, we identify, detect it early, and then going to uterine massage regularly and until the uterus is contracted, and giving O is oxytocin drugs. So here, the WHO, they are talking about 10 international units intravenous oxytocin injected or diluted in 200 to 500 ml crystalloid. But in our guideline, what we are recommending in our national guideline is 5 minutes slow intravenous over 1 to 2 minutes, and to repeat it if necessary. So here, this decision we have taken after discussing and with the agreement that considering a woman who is bleeding and who is already tachycardic and hypotensive, and on top of that, if we give 10 units, there is a safety issue. There is a possibility of syntocinon causing problems, and we have to be more careful. So that is why we are not telling to give 10 units straight away. You give it, as 5 units, and if necessary, you repeat. And giving the infusion also for convenience. Now, already all of us are very, familiar with the syntocinon infusion, putting 40 units in 500 ml ringalactate or normal saline and giving it as 125 ml per hour. So we are recommending the same thing, rather than, we don't have 1000 ml bottles also, and adding a smaller dose of syntocinon, all that. So considering we have recommended to give oxytocin as 5 international units slow IV over 1 to 2 minutes, and repeating it if necessary, and to start the infusion at the same time as a 10 units per hour infusion, right? So that is 40 units, 500 ml. Then the tranexamic acid, again, we are not recommending to dilute, because it's taking time for practical purposes. When a patient is bleeding, taking 200 ml crystalloid and, to dilute, adding and all, it is not really necessary. We can take 10 ml and give it slow intravenous over 10 minutes. And the IV fluids is the other element. So IV fluids for volume resuscitation is given separately. In here, actually, large volume, now 20 units and in 1000 ml, but according to WHO recommendation here in the E-motive, so you are giving about 250 ml per hour. And here, so that the volume management is also done with syntocinon. So we are doing oxytocin drug separately and volume management separately. So you can give, according to the needs of the woman, you give IV fluid separately. And then the other E, the last E, is for escalation and escalation of the management. So they are all the clots should be removed, tears should be repaired, and then the calling for the multidisciplinary input and all come in there in the escalation part. So if the first response bundle does not work, who should be informed? All the multidisciplinary team should be informed using the ISBA communication system, where the anesthetic team, depending on the hospital, the medical officer or the registrar and senior registrar, and including the consultant anesthetist should be informed. And even in the labor room, it is expected that the anesthetist to go there and to join the multidisciplinary team in the management. Right. So there are, now this part, escalation criteria is not mentioned in our guideline, but in this consolidated, the latest consolidated guideline of the global health agencies, they talk about this escalation criteria, where the continuous uncontrollable bleeding is one criteria. If the measured blood loss is reaching 1000 ml, or if the woman is unstable, and especially if there is a severe genital trauma, escalation should be done, and presence of any red flags. So red flags also they talk about, which is not included in, because we are talking about Meo's chart, everything is there, but in the absence of Meo's chart, it is good to know all these red flags of life-threatening PPH. So if the woman is drowsy, confused, tachypneic, blood pressure is less than 80, heart rate more than 130, shock index going above 1.7, blood loss more than 1,500 ml, oliguria, bruising, and some results of these investigations. This part, I think it's very unlikely to have in the early emotive stage, but depending on the facilities available, it could be available. So there are, hemoglobin less than 7, lactate more than 2.6, and all these things are there as red flags. Right. So if active bleeding is present and signs of shock appearing, we have to recognize this situation as a life-threatening emergency, and quick actions should be taken without delay if we are to save the life of the woman. So should be managed in an adequately equipped operating theater in the ideal situation. And so that means we have to take the patient to the theater, but at the same time, so this is a multidisciplinary decision anyway. So early involvement of appropriate senior staff is essential here. So the consultant anesthetist, consultant obstetrician, and the theater in charge nursing officer all should get together now to do a proper management without leading to any delays. So the teamwork, resuscitation, monitoring, controlling bleeding pharmacologically and surgically, and preventing lethal triad, all should go hand in hand. It's also a bundle. So all these things should be attended to without, trying to manage as a sequential manner. One after the other, not one after the other. One must try to do everybody together. The multidisciplinary team should attend to all these things as a bundle again. Right. So this infograph shows, the top end operator, how to manage, right? The top end operator. Usually the anesthetist is one of the top end operator. The bottom end operator is the obstetric team, right? They are the bottom end operators. So what is to be done by the top end operator? IV access, uterotonic, giving tranexamic acid, taking blood samples for investigation and cross-matching, monitoring, And then so that is assess and act. So assess and act, it is not only the top end operator, the bottom end operator also is doing assessing and acting for that. That is assess uterine tone, remove clots. So everything is going at the same time. Assessing uterine tone, removing clots, examining for tears, catheterizing, and then doing the stabilizing the patient. Both sides should go together, and then taking a decision whether to move the patient to the operating theatre now for further management under anesthesia. Right. So the resuscitation, I am not going to go into detail because it's taking time already late. So you know the basic things. It's important to keep the saturation of a pregnant woman more than 95. So giving oxygen and then putting 214 gauge cannulae and draw blood 20 ml. To do all these investigations, the cross-matching and taking a rotem sample into the INR bottle is important. And reserve blood 6 units and 20 units cryo and 6 to 8 units of platelets and 4 units FFP. And the fluid used for resuscitation should ideally be warm crystalloids preferably. And preferably it should be ring lactate rather than normal saline, because you should be using large volumes of normal saline. Can cause problems, hypochloremic acidosis. So, and starting blood as soon as possible with, if cross-match, normally after normal delivery, cross-match blood is not available unless it's already anticipated high-risk patient where we recommend to have 1 unit blood reserved, but otherwise you may have to start with uncross-matched group specific or O negative blood until the cross-matched blood is available. And it is very important to keep the patient warm and document the vital signs and shock index every 5 minutes and communicate with ISBA if further surgical interventions are needed. And then if we have to transfer the patient to operating theatre, don't forget to give oxygen, continue resuscitation and continue monitoring, warming, and external aortic compression is recommended, where you apply pressure. Actually, this is done by the obstetric member of the obstetric team. On the left side or over the abdomen, applying pressure. So that also helps to keep the blood pressure up. If a patient is on the verge of collapsing, blood pressure is going to become very low and going to become unrecordable. This aortic, external aortic compression during transfer will help to keep the blood pressure at a reasonable level rather than, dropping drastically and becoming unrecordable. So to prevent that happening. So aggressive volume resuscitation is very important, where you rapidly restore and maintain the intravascular volume to have to maintain adequate cardiac output and tissue blood flow and oxygenation. And it is very important to take all measures to minimize developing the lethal triad from the beginning, not in late stages, from the beginning. So these are this is what we expect and what is given in the guideline. So there are risks associated with volume resuscitation. We all should be aware about it. If managed inappropriately, the patient can develop dilutional coagulopathy because of large volumes of crystalloids and FFP given to the patient, and that will aggravate bleeding further. And fluid overload will cause pulmonary edema, desaturation, and which will need later ventilation in ICU, and patient may develop complications of all the infection, pneumonia, and patient may die of later on. So that is all related to fluid overload. And metabolic acidosis and hypochloremic acidosis with large volumes of normal saline when you give more than 2 liters. So that is why we preferably request to give ringalactate and limit the saline use. Anyway, total crystalloids also should be limited to less than 1.5. And hypothermia should be prevented by warming. So all the problems can happen when you are pumping cold fluids to the patient to keep the volume, but you have to keep in mind that the fluid should be warmed all the time. And the acute kidney injury may develop immediately after, not during surgery anyway. It is a post-op problem, which can happen with the use of large volumes of colloids. So tetrastarch and all. So that is why we are not recommending to use colloids also. And fluid overload may lead to paralytic ileus as well. Gut edema and all can cause problems. So this is lethal triad: coagulopathy, metabolic acidosis, and hypothermia developing together will kill the mother. So this is finally what is happening. The mother will die of these things. These three things have occurring and progressing together will cause death of the woman. So coagulopathy is actually initially it's a dilution coagulopathy, but in amniotic fluid embolism or abruption there can be DIC developing from early stage. But generally, normal vaginal delivery and postpartum hemorrhage, where what you see first is dilutional coagulopathy. So, which is actually a preventable thing by doing a proper volume resuscitation. So, you can do it, and hemostatic management as well. So, then the metabolic acidosis is the other thing, and hypothermia. All these things can be prevented or at least minimized so that it will not progress further, causing poor outcomes. So we have to restrict crystalloids to total less than 1.5 liters or preferably ringalactate. And it is recommended in NATA consensus guidelines or statement that 1 to 2 ml for each ml of blood loss is recommended. And colloids should preferably be avoided, as I mentioned earlier, and replace blood loss with blood. Now, in this severe massive hemorrhage, you cannot, try to restrict blood transfusions. We have to give blood, replace blood loss with blood, and as soon as possible, even with O negative and uncross-matched blood, the blood bank will issue uncross-matched group specific and O negative. There is no problem in this emergency situation. The transfusion medicine specialists have agreed to issue blood without cross-matching at this stage of management, right? So rapid replacement of already lost blood and ongoing blood loss need the replacement, rapid replacement, and the rapid warmer infuser is very useful to pump blood. We can pump about 750 ml of blood per minute. So one blood bag can go in 1 minute. So only thing it takes a little time to set the warmer, but it is worth. Especially in a patient who is bleeding very rapidly. Otherwise, we have to use the normal warmer, the drum warmer, also with the pressure infuser bag to pump the bag, so that. But the problem is there we have to change the bags, and air can enter the circuit, and all the problems are there. But with rapid warmer infuser, we can avoid all these problems and continuously give blood, and so that the patient can be, we can avoid collapse or unrecordable blood pressures and so on by maintaining the volume. So here actually we maintain the volume with blood, and we correct acute anemia as well. And FFP and human albumin is not recommended for volume replacement. And intraoperative cell salvage can be used if it is available, but I know it is not available to us in Sri Lanka. But in future, we have included intraoperative cell salvage also because it should be available actually. Though we currently have that problem. So soon I think you should be able to get all these equipment. So the target blood pressure, permissive hypotension of, so the mean arterial pressure between 55 to 65 or systolic blood pressure around 80 is okay during rapid bleeding phase. We don't have to have a normal blood pressure, and in fact the volume loss also can be controlled with the low blood pressures. And what we have seen is giving noradrenaline infusions at this stage, and that is also not recommended, because by giving noradrenaline to maintain blood pressure, we are causing further vasoconstriction, giving rise to severe metabolic acidosis later on, because of the perfusion is getting affected, the organ perfusion. Vital organ perfusion will be maintained, but there is a risk of. So actually here what we have to do is to replace the volume, not to cause vasoconstriction, further vasoconstriction, but we want to dilate while filling the lost volume, replacing the lost volume. So here in the theater, internal aortic compression is very useful at this stage. Intermittent internal aortic compression, which will help to keep the blood pressure while we fill the circulation. Rather than giving, the noradrenaline infusions, aortic compression is actually much better, and you may use some, boluses of ephedrine or phenylephrine. Those are, judicious boluses can be used, but the noradrenaline infusions cannot be recommended at this stage of management. So consider invasive monitoring because it's very useful to have, especially the blood pressure, invasive blood pressure monitoring. So then the targeted hemostatic management is what is recommended in the guideline if it is available, if that facility is available. So, the fibrinogen level in pregnancy is twice or double that of non-pregnant. So the pregnant woman has a higher fibrinogen level, twice as the normal non-pregnant person. So which is the factor dropping early in obstetric hemorrhage. So if it is less than 2, if we can measure it, but the problem is we can't get fibrinogen levels immediately during the bleeding situation. By the time we get the report, everything has happened. So that is why the thromboelastometry is useful. There we can get an assessment of fibrinogen by using the SID-10A5. So if fibrinogen is less than 2 grams per liter, there is a 100% positive predictive value for progressing to severe hemorrhage. So we can predict it if we have the levels. If we know the levels, then we know this patient will go into severe hemorrhage. So we have to correct it immediately then and there. So therefore, fibrinogen is the most required hemostatic factor for correction in postpartum hemorrhage. So the sources of fibrinogen are fibrinogen concentrate and cryoprecipitate. So FFP, the problem, I will come to that later also. So problem is this is prepared from adults having half the fibrinogen level of pregnant women. I have explained it earlier. So we are starting with, and now the pregnant woman's fibrinogen is already dropped. So we have to give, if we give product with lower fibrinogen level, it's very difficult to bring up the level towards normal in a pregnant woman. So you need, even with large volumes, it's very difficult to correct. So that is why it can lead to fluid overload with transfusion-associated circulatory overload and diluting the remaining fibrinogen in the circulation, that is dilutional coagulopathy. So therefore, FFP is not a good source of fibrinogen to replace fibrinogen, the dropped fibrinogen level in postpartum hemorrhage. So therefore, ROTEM guided management is preferred over massive transfusion protocol. So because the ROTEM or TEM identifies hemostatic defects very quickly, in minutes, in 5 minutes actually. If we have the ROTEM machine ready, in 5 minutes of sampling and putting the sample into the machine, you can get, because A5 is in 5 minutes, you get the report. You can report in the sense, you can see the line visually on the screen and you will get the number as well. So, and it facilitates immediate correction, especially if you have fibrinogen concentrate, like giving an antibiotic, you can immediately give it. Prepare it and give it immediately. But cryoprecipitate, it takes some time to thaw. But in anticipated hemorrhage, if you keep the cryoprecipitate ready, it can be given immediately. So that is why in placenta percreta accretas, you have to have at least 10 to 20 minutes cryo thawed. So it is ready in the theater, so you can give it immediately. Right. And the diagnosis, so that the diagnosis and treatment can be done at the same time, and that is called theragnostic approach. So, and then if the woman is bleeding further, you can repeat it and further corrections can be done. But normally the calculated dose usually correct it immediately. Now here it's difficult to see. This is the flow chart. We have a PPH flow chart. We have included in our guideline, but it's difficult to read here. So I have taken sections. Now before going to that, I have to show there are 2 arms. Now initial, this part now we have discussed. Now then there are 2 arms to manage the hemostasis. Now when ROTEM is available and when ROTEM is not available, what to do is given here. And then to contact transfusion physician and the hematologist and going to further management, right? So, so here, when ROTEM is available, the first step is to correct, as I told you. When the blood loss is now more than 1000 ml or reaching 1000 ml, that is the time to do the ROTEM sample. And then, so you get the report, and if it is, our target is to keep more than 12. So if it is less than 12, you can use the validated calculation chart and decide the dose and give it immediately and correct it. So that is what we expect from the anesthetist to do. Further management can be done with the transfusion medicine specialist or the hematologist. We invariably we need their support, but you know, practically in our hospitals, the anesthetist is the one who you have to take responsibility for the initial hemostatic management. We can't be, you know, calling and finding them to get advice, because we are the people who see it first. So we should be able to, you know, detect this and correct, start correcting. And actually, if you do this correction, and provided the surgical management is done properly, surgical control, then the bleeding will stop and we don't have to go for all these massive transfusion protocols or massive hemorrhage management. So this initial management part, the anesthetist can do. This is what we want to highlight in our guideline. It is the anesthetist's responsibility to correct, initiate the hemostatic management. So this is a normal report. here the lower one is the fib-tem and the upper one is the extem. So you see it. It is a normal one. You can see the A5 is 13 here, and A5 48 extem is a normal. So it is a normal report. And when there is what you see normally in most of the patients is this fib-tem. Extem is normal and fib-tem is low. Where you get the width of the graph of fib-tem is, you see it as a line. And you can read the number as well. So here it is 8. Sorry. You see A5 is 7 here. So that is low. So that needs correction. So how to correct? So here, this is the first step. So even if the extem is abnormal, the first thing to correct is fib-tem. You don't have to jump and correct everything as the first step. First step is always to correct the fibrinogen problem, because by correcting fibrinogen, you can correct the extem abnormalities as well when it is not severely deranged. If extem is severely deranged, then you have to, so there is a calculation chart, I will show it to you. So anyway, these things you can discuss with the transfusion medicine specialist and do. So when fib-tem A5 is less than 12 and minor derangements of A5 extem is there, we don't have to give platelets. We don't have to correct. But when fib-tem A5 is normal, more than 12 and it is deranged, then you have to give platelets. So that is what we are supposed to do. It is not difficult. So when ROTEM is not available, it is recommended. Now you get down the box 1. It has 2 units of red cells, and box 2. So once that is over and still the patient is bleeding, then the box 2 has 4 units of red cells and cryo 20 units. So if you are giving all 4 units of red cells, so altogether you have given 6 units by then. So you have to give cryo 20. So here, this is the change we have done. So in our guideline, hemostatic management, we are recommending to give cryoprecipitate as the first thing. If cryoprecipitate is available in the hospital blood bank, cryoprecipitate is the hemostatic factor you have to give in the box 2. No FFP, no platelets, only cryo to be given. So if you have to give 6 units of blood, finally you are giving only 20 units of cryo. You are not giving any FFP, 4 units, platelets, 6 to 8, all these things we have avoided giving. So unnecessary blood products we are not giving. But of course, we know we are giving it blindly. There is no evidence to show. But here I have to say about 70% of patients with severe hemorrhage, going above, say, 1,500 ml, what is deranged is A5. Fib-tem, it will be less. So that is why we are asking. In about 30% of patients, there won't be any derangement, even with massive blood loss of, say, where you need to give 6 units of blood. Sometimes ROTEM will appear as normal. So then we don't have to give any products. So we are avoiding unnecessary blood products transfusion. But so here, when ROTEM is not available, we don't know. But so it is good to give cryo rather than giving FFP. Again, both without knowing the reports, we are giving those products. So it doesn't matter whether you are giving cryo or FFP, same problem. You are giving it blindly. No, there is no target to correct or anything. But so it is better to give cryo, and because most of the time what is needed is fibrinogen correction. So if cryo is not available, only you are supposed to give FFP. Because at least you have to give FFP when cryo is not available. Right. So here we have included this box in the flow chart to explain why human fibrinogen. The fibrinogen is the best to replace fibrinogen deficit in PTH. The second best is, cryoprecipitate, and why FFP is not good. Here it is explained. I think I have explained it already. I am not going to go back to that again. So the targets we have to achieve during this management is hemoglobin of at least 8. So we don't expect to have 10, 11 like that. It is the target is 8 to 9 grams. FibDem-A5, as I said, it is 12. XTEM-A5 more than 35. If you don't have ROTAM, then INR APTT to keep less than 1.5. In addition, the calcium should be kept normal more than 1. Temperature should be more than 35. pH, you have to do a blood gas and see whether there is any metabolic acidosis. Then potassium also need to be checked. So then to stop bleeding, the bimanual compression, external internal aortic compression, then the drugs pharmacological control, ergometry, 500 micrograms, IMO IV can be given slowly. And if you are repeating ergometry, you can repeat only after 2 hours. We have gone through so many guidelines. So what is recommended is if you have to give ergometry, you can give it after 2 hours. So by then, most of the time, it is not needed actually. So only 1 dose. So syntocinon, as I explained earlier, and misoprostol is very important, pectal, 800 micrograms, and O prostaglandin F2 alpha, 250 micrograms, always intramuscularly, no intravenous administration of carboprost or prostaglandin F2 alpha. So repeat, it can be given intramyometrially and repeat it every 20 minutes if needed to a maximum dose of 2 milligrams. Tranexamic acid, as soon as PTH is diagnosed, you have to give, and then after repeat it after 30 minutes. And then further tranexamic doses should be decided by the TEM report, ROTAM report, where ml/xtem, if it is more than 5, then tranexamic acid is indicated. So then other surgical measures, this hysterectomy or internal iliac ligation and so on will be needed. So pharmacological management, most of the things I have gone through, right? So then always we have to take measures to prevent the lethal triad. So hypothermia, warming the patient, warming fluids. The cryoprecipitate, you don't have to warm the fluid, the crystalloids and the blood. That is what you have to warm, and the patient warming. And actually, if the facility is available, you have to measure the temperature of the axillary temperature is usually measured in the patient, and make sure the patient is not hypothermic. So keep all the measures, take all measures, and prevent metabolic acidosis by restoring intravascular volume and maintaining blood pressure, minimizing vasoconstriction and restricting crystalloids, and using lactate preferably, and coagulopathy, avoid dilution and coagulopathy, and replace the required factors only without delay. So anesthesia in unanticipated major hemorrhage. So here the patient is cardiovascularly unstable, so you can't talk of regional anesthesia. The general anesthesia is indicated. So it is very, very important to contact or communicate. Actually, the consultant anesthetist should come in, but there are instances there is no time. Maybe the consultant is at home at night and was not informed in the labor ward, and now only the consultant is getting to know this. So you have to discuss with the consultant, and while consultant is on the way, you can't wait. The junior anesthetist has to start the anesthesia, right? So communicate and get the instructions and provide anesthesia. So aspiration prophylaxis should be given intravenously, and difficult airway trolley should be kept ready, and make sure that large bore cannulae, 14 gauge preferably. Preferably, I prefer the radial side actually, because the other side, the back of the hand, most of the time tend to go out when you're pumping fluids. So use a straight vein. I personally prefer the radial side. Normally, the pregnant women have big veins. So these things should be actually inserted early. If you try to, if you wait till the late stages, it will be very difficult to cannulate. That is why in the early stage itself, we have to insert large bore cannulae. Right. So most experienced anesthetists should intubate the patient until the help arrives, and preferred drugs are ketamine and succinylcholine, and intermediate can also be considered. It should be a modified rapid sequence induction with cricoid pressure. Then don't forget to give prophylactic broad spectrum antibiotic, because these women are very prone to develop postoperative sepsis. So usually you give, other than the normal cesarean section prophylaxis, you have to give additional antibiotic like gentamicin, 4 to 5 milligram per kg dose. Right. And make sure the urine output, you have to look at urine output, and if the pressure is okay, you can consider giving a small dose of furosemide also at this stage if the patient is stable cardiovascularly, right? Make sure that the urine output is maintained. So in placenta accreta spectrum disorders, tranexamic acid is recommended to give as prophylactically. Any woman with high risk for hemorrhage, prophylactic tranexamic acid is recommended in our guideline, as well as in consolidated guideline also. It is recommended to give prophylactically, but not for all other cesarean section, other normal cases, right? Thinking that patient will bleed. Here, in the presence of risk factors only, it is recommended to give tranexamic acid 1 gram IV slowly. When there is a placenta previa after cesarean section, that is now a woman with previous cesarean section and coming with placenta previa this time, post cesarean section. So there is a very high chance of having placenta accreta, that is adherence of placenta. So so that specific ultrasound features, you have to look, do the ultrasound, I mean the obstetric team should look for the presence of accreta per accreta before cesarean section. Sometimes these things can be missed. Anesthetists can look for it, see whether they have done it, and make sure that it is excluded. Most of the time it can be, it is very useful to do ultrasound. So that we can have an idea whether there is involvement, bladder involvement, and increased vascularity, and so on. So that we can, it's a preventive measure. We know it, and so that can take adequate measures. So timing and place of delivery also should be decided to facilitate the access to intensive care and supportive care, like availability of blood and blood products. And consultants should always be there. All the consultants should be physically involving with the patient during surgery. And it is important to educate the relatives as well regarding the risks. So it is a planned surgery, and plan should be made well before the operation, and it should be discussed with the obstetrician. And then make sure all the facilities are available. If facilities are not available, it is best to transfer the patient to a hospital with facilities. So it is very, very important. And the consultant anesthetist and the obstetrician should be physically present in the operating theater before commencing anesthesia. That is very, very important because we cannot ask the juniors to start surgery while to come to the theatre if necessary only. That is not acceptable here. We are insisting on that, both the obstetrician and the consultant. So consultant involvement should be there from the beginning of surgery in case of placenta accreta or perpetual patients. So mode of anesthesia may vary depending on the anesthetist and the obstetrician's preferences. It may be combined spinal epidural or GA. So ICU bed should be available in the same hospital. Not in another hospital, because then you have to transfer the patient. The patient may be unstable, patient might bleed, so there can be problems because it's a planned surgery. Right. So it is very important to communicate with the family and explain the situation and what happened after the TPH, and then documentation is also very important. With not forgetting to include the amount of total blood loss and fluids and the blood products given and all that, and the surgical interventions and all. So if a patient needs transfer within hospital or to some another hospital while bleeding, right? While the woman is bleeding, it is important to do these things, inserting to cannulae 14 gauge or 16 gauge, and to give fluids 500 ml over 30 minutes and start second 500. And if compatible blood, this is for the anesthetists who are in the smaller hospitals. They are for some reason some facilities are not available and need to transfer the patient. These things should be done before transferring. So if compatible blood is available, start blood before transferring and give oxygen to the mother during transfer, give tranexamic acid before transfer, and take temporizing, what are called temporizing measures, such as this external aortic compression to be applied during transfer by the obstetric, say a SHO or even somebody who knows how to apply it properly while the patient is in transit, so that the blood pressure can be maintained or at a reasonable level. And it is important to communicate with the receiving obstetrician and anesthetist before transfer, and medical officer or preferably an anesthetist, if available, MO anesthetist should accompany this patient with nursing staff. And monitoring should be continued with a multi-parameter monitor, preferably, and to take all documents and write down everything, the blood given, the fluids, amounts of fluids given, and so on. So it is important to do that. So it took a long time. I'm sorry about the technical issues. So what about the take-home messages? So it is said that saving life after major PPH is a race against time. Actually, it is a race because time is the most important thing, avoiding all these delays and acting to control this bleeding and somehow to stop it. Right. So no woman should die from postpartum hemorrhage because help came too late. Use reappraised definition to avoid missed cases. Now I have told you what is reappraised definition. Use objective methods of blood loss assessment for accurate diagnosis. Objective, not subjective, right? And use Meo's chart or red flags to recognize deteriorating woman, and use first response treatment bundle, that is the emotive, to avoid delays of sequential treatment. Sequential treatment is not acceptable. It should be done as a bundle within 15 minutes, bundle of care, and maintain urgency across the prevention, diagnosis, and treatment, and early involvement of the anesthetic team, even in the labor room. So we are supposed to go to the labor room that is recommended in the guideline when the first response bundle is not working. Now it is not working, patient is continuing to bleed. The anesthetist should, join the obstetric team at that stage. Delays in securing hemostasis can progress to a preventable death. So if there is a delay in correcting, this is what we see most of the time in our preventable deaths in the maternal death reviews, not doing proper hemostatic management, but which is not noticed most of the time. And it is very obvious, giving large amount of FFPs and unnecessary products and circulatory overload, ventilation, and going. So that is a delay in securing hemostasis, so which can lead to death. Okay, right. Thank you.
Right. Thank you. There are a lot of questions in the chat box.
Yeah.
But you have already answered most of those questions during your speech.
Okay.
But there are few more. One is if clot is not formed at all. So that is like a DIC situation.
Yeah.
So what products to be given? Somebody asked about.
Yeah. So as I said, it is cryoprecipitate or fibrinogen. Because so anyway, if rotum is there, you can see that in the rotum, fibtem and extem. The test you need are the two tests. The most important one is fibtem. The next one is extem. We don't need other things. It's a very late requirement. So if blood clot is not forming, actually, what you have to do is sometimes you may have to give a cryo large, volume. We have given sometimes in one case I can remember we gave 60 units. 60. And fibrinogen, I think similarly fibrinogen also, when fibrinogen was available, there was one case who was transferred from some other hospital and she was bleeding. And Fibtem A5, it was just a line, thin line only. So by correcting that, we were able to stop that bleeding. So that is what we have to do. So even in the absence of rotum facility, what I suggest
actually
is
what they are asking is when you have rotum.
Yeah.
And in rotum, the clot is not formed in both, both extem and fibtem.
Right. That means severe derangement.
Yeah, severe derangement.
Severe derangement. So you have to correct accordingly. Now we have the rotum flow chart. Follow the chart, so you can correct it. But I mean, at this stage, you need definitely the transfusion physician's help as well. So the anesthetist is not going to manage it alone anyway, especially if you are not very experienced with the rotum guided management. So it is correctable. And most of the time, you may have to give in such a situation platelets, and if the CT extem is deranged, say more than 100, you have to give FFP as well in such a situation. So all three products, but this recombinant factor 7A and all really needed. I think it is not available in the country now. It is not needed.
Then somebody asked about methylagometrin 0.2 milligram.
Yeah.
So they're asking whether it is that is enough 0.2 milligram methylagometrin.
Yeah, 0.2. 0.2 is the dose methylagometrin. The ergometrin dose is 0.5. So we are not supposed to repeat. And in one guideline, we have noticed during the preparation of this the development of our guideline, only I think Australian and New Zealand, there they recommend repeating ergometrin, where they give 0.25 at a time First dose 0.25 IV or IM, and then repeat it after 5 minutes. They don't give 0.5 at once. You know, what we give is 0.5.
In fact, there was a question on that as well in the chat box. Whether to give ergometrin half dose IM and half dose IV, somebody asked about.
Yeah, that can be done. Yeah, that is also recommended in some guidelines. But in our guideline, what we recommend is this is the second line. This is not first line drug, right? We give syntocinon first, start the infusion, then misoprostol, and then consider ergometrin, and it can be given. Slow intravenous or IM. You can, yes, and only once. If you need to repeat, you can repeat only after 2 hours. If the initial dose is 0.5, if you have given 0.25 of ergometrin, like in Australian, New Zealand guidelines, then you can repeat the other 0.25 after 5 minutes. It's clear.
Then somebody asked about tranexamic acid in DIC, whether it is indicated in DIC situation.
DIC situation is a complicated situation because there is, some, formation of fibrin clots as well, and then, disseminated intravascular coagulation. So there you have to be careful with that. I think at that stage, we have to get the hematologist and the transfusion medicine specialist advice as well. So we cannot manage those patients alone as anesthetists. Okay.
Right. Okay. Thank you for your informative presentation. And I think it helped everyone. Thank you very much. Good night.